Hey everybody, this is Justin Zitch. I'm excited to be back with you guys again today and go through another grand round session. So we'll go ahead, we're going to use a really similar format to last time, and we'll go ahead and get started here. But before we dive in, I wanted to just check in with you guys and make sure. I know that this semester has been different and provided a lot of different challenges. I was interviewed a couple weeks ago, and somebody asked me what was the thing as a student that I wish I would have done differently or that I would have emphasized more. And it was actually more focusing on the clinical reasoning and asking the questions like why, more so than practicing the skills. Of course, the skills are important, and you guys will get a chance to get a lot of repetition and exposure to the skills, and that'll come with time as well. But this is a really unique opportunity to learn and gain a lot of advanced clinical reasoning at a really early stage. So honestly, while it doesn't feel like it right now, you guys may end up coming out ahead once it's all said and done as far as your ability to work with a patient not only through an intervention, but especially in a case like today, an examination, be able to really provide through the repetitions you're getting in this course a lot of advanced clinical reasoning. So, you know, each opportunity is a little different. I know this is a tough and trying time for everyone, but I hope everyone's making the most of it and getting a lot out of these repetitions. So for today, we're going to go through and we're going to focus again on highlighting an evaluation like we did last time. So this is another presentation of a real life case. We're going to use a similar format. So in that format, we're going to focus on the same thing. I'm going to show you guys the intake paperwork. We'll stop and reflect. We'll then have a chance to think about what subjective questions we may want to ask after hearing from the patient, stop and reflect, tweak some of our information if we need to, and then how we would want to structure an exam. So using the theme from last time, I know you guys have made it further along in the semester. Everything's fair game at this point. I won't ask an obscure foot condition that you guys haven't been covered yet, but part of today is making sure that we have the ability to identify with great detail the areas that you guys have covered, and if it's something else, at least being able to identify that it's something that may warrant a different style of evaluation or potentially a referral. So we'll go ahead and just jump right in. So here's some information about this case. This was a 46-year-old female. She came to me via direct access, so she hadn't had a chance to see a physician yet. As far as her numeric pain rating scale, at a worst, her pain appears to be on the right side of her lower back and the right groin, was a 5 out of 10. At its best, it was a 1 out of 10, so she always had some level of pain, and at rest, it made it to a 3 out of 10. Her Oswestry Disability Index she rated herself at a 40% disability. Past medical history, the only thing that she marked on the list was history of broken bones, and then cancer. And her occupation, she works as an administrative assistant. So that is our intake information that we have so far. So going back to the clinical reasoning template that I've given you guys from before, take a moment here and just start by listing all the potential sources for this patient. What could be the cause of that groin or back pain? Are those connected? Are those not connected? Are they two separate things or just one? And then just based off of the small amount of information, if you can, try to rank your differential diagnoses and your clinical impressions based off of that. So I'll give you guys a moment and trying to be a little bit more organized today with the slides. So whenever you guys see a stop sign on the slides, stop at the end and pause it. And then once you're ready to resume, go ahead and play and I'll keep going. So take a few moments. Think about your initial clinical impression for this patient, and then we'll come back together after that. So when I look at that pain diagram, there is a lot that could be involved. So we could list out individual structures and ligaments in the hip. Could that be potential early arthritis of the hip itself, since it is located in the groin? That could be something that shows an arthritic pattern. Could it be any sort of non-musculoskeletal area? So in the low back, I know that the kidneys are in that area. In the groin, it points to some pelvic structures. So could that potentially be a non-musculoskeletal sign that exists? But then also that's a really common area for low back pain. So what I don't know yet is if that pain radiates consistently back and forth. If it's an all or none, so does it start at the back and work its way down through the groin? If it does, that may be something where I'm stopping and thinking about a potential radiculopathy or a facet referral pattern of the lumbar spine, so one of the higher segments, L1, L2, etc. That could also be a muscle strain, so for example, the quadratus lumborum, maybe the multifidus structures or some of the erector spinae, as well as some of the adductor muscle group and the hip adductors. So a lot of things that could potentially be involved. One thing that's higher on my list right now than it normally would be is potentially a cancerous lesion. So she has a history of cancer, and we know when we talk and think about cancer that one of the biggest risk factors of having a malignancy or a cancerous lesion is a past history of cancer. So could this be potential metastases of something that happened or reoccurrence of something that happened earlier? One of the spots where that does happen more often is a potential bone metastases in the hip. So that's something that's definitely still on my radar right now. So those are some of the main things that pointed out to me. And when I take a look at it, yes, I mentioned that, potential cancerous lesion could be higher because of that risk. So I'll put it kind of middle of the list for me, higher than normally it would be. But at the same time, this could still very well be a lumbar radiculopathy, which I'll go ahead and put as my number one right now. A lumbar facet pain with a facet pain pattern, which I'll put as my number two. And we can't rule out the prospect that this could potentially be two issues. We haven't really heard from the patient yet, but it's very common, very likely that somebody could have a acute back issue and then also have an acute or chronic issue in the hip. So are we looking at these two as one common condition, or is this somebody with different levels of condition going on at the same time? So those are some of the main things right now that are sticking out to me. I mentioned arthritis from before. She is a little young, but again, I don't know her history. Maybe she was involved in high impact sports. Maybe she was a gymnast or was involved in military training where they had to do jumps and lands and things like that may lead to some accelerated arthritic changes. And then the other thing that I haven't mentioned yet, which we'll see if this shifts as we go forward, is if this is potentially a sign of more of a motor control issue as a result of decreased core activation. And in particular, as a 46-year-old female, does she have a history of childbirths? Were they natural? Were they cesarean section? Both have their own side effects as a result, but how could this potentially manifest into a kind of a lumbopelvic pain pattern? So those are the main things that are on my radar right now. So now let's shift gears and go through hearing from the patient. So I'll start with just my open-ended question. I'll go ahead and just throw out a sample. So I see that your referral mentioned low back pain. Can you tell me about your low back pain and what's been going on? So her response to this: I've been having pain that radiates between my low back and right groin. It happened for the first time 6 weeks ago and got a little bit better. but then recently came back and was even more painful. The only thing that helps is Advil. My PCP referred me to you. All right, so I apologize. This was not a direct access patient. This was actually a referral from a primary care physician. So I mentioned that before. I apologize. So going forward, just to make sure that we're viewing the patient as the same, this is somebody who came from a referral from their primary care physician. But just given that little bit of information, just when we let her talk before we start to organize our questions, going back to your guys' clinical reasoning template, what additional questions, based off of not only the clinical impressions that I mentioned, but the clinical impressions that you went through from before, do you have based off of this information? So again, I invite you to pause this slide here, and once you fill out the template, we'll come back and go through some subjective questions. So based off of what we have here, I actually have a lot of questions, a lot of clarifications. One of the things that really isn't clear for me today so far is the aggravating factors, or if there are aggravating factors. So question that I would have for her is, can you tell me about what makes the pain worse? And then also clarifying afterwards what makes the pain better. Now, she mentioned from before, the only thing that makes her pain better is Advil. So she hasn't found a preferred position, so laying down versus sitting, anything like that. She hasn't found a preference there. As far as aggravating factors, again, she really hasn't pieced together a specific motion or a specific activity that causes it to be worse. So, for example, bending forward, and if a patient is struggling with this, I may go through and start to use some closed questions just to see if I can try to get a little bit more of a sense of things that may help. So, for example, if I'm worried about a potential disc lesion, I may ask about activities that have to do with bending, lifting, and twisting. If I'm worried about a facet issue, this may be an opportunity for me to start to ask questions that maybe focus more on pain with extension, or pain with side bending towards that right side, or if I'm worried about a muscle strain, again, those may be painful in both positions, but we can start to ask a couple closed-ended questions to see if we can almost kind of not necessarily guide the exam, because again, it's important that we don't control the pace of the exam. But if somebody's struggling with information of what to tell you, give them examples, and then hopefully that helps spur their memory to keep going forward. Now, so I did that with her. I was interested in asking bending forward and bending backwards. So I asked both of those. Neither of those that she noted led to an influence in her pain. Same thing with rotation. She did note that if she's sitting down for a long period of time, her back may start to feel stiff, but it's just stiff. She said she's always had that. That hasn't been the more recent pain that she's been feeling over the last 6 weeks. So didn't really get any strong aggravating factors from there. I also want to really clarify, and again, I'm going to try to be a little bit more specific with my questions today. Of course, there are questions that we should always ask the patients, such as their goals, aggravating and relieving factors. But what I want to do today is try to give you guys an example of specifically when we're using my top 5 differential diagnoses, can I ask specific questions that are going to help me increase or decrease that probability? So one of the ones that was middle of the road on my list was cancer. So I want to know a little bit about her history with that. So she mentioned that she did, when she was younger, have a squamous cell skin cancer that was removed. She continues to be monitored by her dermatologist, and she actually went and saw a dermatologist about 2 months ago. Everything was looking good, and when she was at her PCP, they did go through blood levels and they didn't see anything concerning. So for me, that helps decrease the probability that there's a potential waking up of a dormant cancer or malignancy because of the recent blood work and the fact that she's had consistent follow-ups. It doesn't completely decrease its probability for me, but it helps for me. It helps kind of give me a sigh of relief to know that that has been screened and is being looked at often by other healthcare professionals. The other thing that I mentioned was potentially a hip issue. So I mentioned arthritis from before. So if I was concerned about hip arthritis, maybe I would ask questions more so about a time pattern of her pain. So is it, if her pain is worse in the morning time, in the front of the hip, that would be something that would help increase my confidence that I should be looking a little bit more at hip arthritis or even an intra-articular hip issue. Or if there's specific positions in her hip that are painful. Again, both of those were negative. So she didn't have a time pattern for her hip pain, and no positions of her hip, which is good, but I still haven't quite figured out the exact nature of her pain. So is it just hip pain? Is it hip and lumbar happen together? Is it lumbar first and then eventually hip happens, or can we trace that line? So I want to know about the nature of her pain. So I may ask her, can you tell me about more specifically about the nature of the pain? Try to keep it open, see if she says anything. And if she has trouble kind of articulating, and this patient did, articulating a response in the lines of what I was looking for, I can ask some leading follow-up questions. So are the two pains connected? Do you feel like you could draw a line between the back and the hip? And when I went through and asked that, she said, no, you couldn't trace a line from the back going around her hip. It almost felt like the two pains were together. They happened together, but they were almost going kind of through the body. So, those points of the anterior hip and groin area, and then going straight posterior into the lower back. Felt like those areas were there. So that to me helps decrease the potential of a lumbar radiculopathy, again, because of the aggravating factors, but also because that pain pattern isn't completely connected in the same way. So now I haven't found any aggravating factors that are movement-based or positions that really change it. The only thing that's really helped is Advil. So I want to make sure that I'm asking questions that help me get more into the non-musculoskeletal pain, so potential visceral sources of pain, especially with the nature of pain feeling like it's going from anterior to posterior. So I want to ask the questions as far as childbirth. So, have you been in labor before? If so, how many times? And then some of the how the labor happened. So was it natural birth, or was it or was it a cesarean section? And she had not delivered or had any children before, so not so worried about pregnancies or potential labor pains or like a motor control issue. And at this point, I don't have a lot of information that's really helping point me in a strong direction. So I want to really dive a little bit deeper, deeper even so much so into the things that I may not be as comfortable knowing what to do if it is true. So one of those, as a 46-year-old female, I'm interested in knowing if she is still going through her menstrual cycles, and if there's any pattern with that. If you remember from before, she did mention that the pain started 6 weeks ago, it got better, and then it got worse again. So what was the time period of that? So before I ask really specifically that way, I'm just curious, have you noticed that the pain is better or worse around the time where you're having your period? And initially, she didn't piece that together, but she said yes. That is something that when it initially started, she felt like she had a cycle where she had increased symptoms. And I clarified from that was increased bleeding, felt more fullness and kind of more cramps and more heightened symptoms during the period herself. So that to me sets off a potential red flag that this may be something that is non-musculoskeletal, based off of that time period. And then if there were any other factors that led to the increase or decrease, whether that is stress or changes in work or anything like that. And she mentioned no, the main change was due to her menstrual cycle. So based off of that information, let's go through and think about our second clinical impression. Okay, so I gave a list of about 5 things, but based off of how many you guys wrote down, how did those diagnoses shift? And now which one is feeling more likely? I'll speak on behalf of myself right now, and I kind of articulated this as we went through. At this point, I'm more concerned about a potential non-musculoskeletal visceral problem, specifically in the area that she pointed. That could be a referral pattern of the uterus. So something like uterine fibroids shifted much higher on my list. In fact, when I gave my list, I don't even think I put that in the top 5, but after going through and clarifying and asking questions, and that seems like that may be one of the more primary causes. Things like lumbar radiculopathy and facet issues decreased. I could still put like a motor control issue reasonably high on there. I don't know if she's going to have any muscle guarding, and if so, that muscle guarding still doesn't really tell me if that's an acute issue that's isolated to the muscle itself, or more of a product of the cause, which may be more of a uterine issue. And then also hip decreased some for me. So take a moment and go through and think about what you want to do at this point. Obviously we go through, and I talked about trying to funnel this information down so that we know how we want to go through the exam. So what does this exam look like for you guys? And are we even doing an exam based off of the information that we have? So I'll give you guys a moment to pause and write out what you would do, and be able to, if you're doing this with somebody else, or if I was here talking to you, explain why you're choosing to or not to do an exam. So I'll give you guys a moment to do that. So go ahead and pause, and then when you're ready, you can go ahead and turn the slideshow back on. So for me, as I mentioned, my clinical hypothesis shifted a lot more to non-musculoskeletal, but that's still just a hypothesis at this point, based off of a subjective exam, and she didn't give the most. It took a lot to get she wasn't the best history teller. So based off of this, yes, it sounds like it may be something that I may not be able to be the primary person in charge of helping, but I don't know that yet. So I do want to go through and do an examination to tease out if there is any sort of musculoskeletal causes. So what I would do for this is go through everything from before. So observation, watching her walk, and she walked fine, watching how she sits and stands, stood in a pretty normal position, no increased or decreased lumbar lordosis. And especially as I'm sitting here and wondering if and what symptoms are musculoskeletal, I'm very interested in going through and doing a upper and lower quarter screen, or a lower quarter screen, just to check and see if anything. She didn't mention any peripheral symptoms outside of her pain area. But at this point, I want to screen all of that out because I'm still trying to see what will be positive from this exam. All of that was negative. Her lower quarter screen was good. Going through mobility testing, her active, passive, her passive physiological motion, her PAs and UPAs were all negative and not painful at all. Her muscle strength was good. Going through palpation, and sorry, let me back up for a second. In the mobility testing section, we also went through and did the same things for the hip as well. So looking at hip active, passive, and accessory motion, those were all non-symptomatic and normal. Muscle performance testing was nothing was significant or painful through the findings. So I'm starting to think at this point that it's not musculoskeletal. So let's make sure with palpation. So with palpation, I focused on some of the back musculature, which was tight and a little uncomfortable, but not in a specific spasm. There was, no warmth in the area or anything else. There was just slightly guarded for the erector spinae, QL, and the hip flexor. At this time, I did go through just to make sure, because I mentioned uterine symptoms. It could also be a GI-based symptom as well. So I did the McBurney's test, and essentially all that is I put pressure down on the abdomen and did a quick release to see if there was a positive, and there wasn't. So that and going through and feeling around the abdomen, there was nothing that was significant. Special tests, Faber, Fader, everything for lumbar spine, they were all good. And at this point, I wasn't so worried about doing a physical performance measure. I had a pretty good idea of what was going on. So this seems like a non-musculoskeletal source of pain. To the best of my ability, if I had to make the assumption, I would say that this probably would present and be diagnosed as uterine fibroids. But that's not necessarily the point of today, is to sit here and make that diagnosis. I'm not so worried about doing that. But if you look at the referred pain here on these charts, you can see in the area of the ovaries and the uterus and the ureter, those are very similar areas that are covered. So that's something that, based off of that area, that could be a referral from viscera. And really, a lot of people that are coming in with back pain and hip pain, we're going to get a lot of carryover between a lot of important areas, from the bladder, appendix, of course, colon, small intestine, areas that may need more emergent care, but may not always manifest strictly as a very obvious sign or symptom. So neat, we found that this person needs to go back and see a professional and see what we can do to screen this out. But what does that look like? What can we do as a physical therapist to help assist with this? So here, this was taken, and essentially what it did was help to triage 4 different steps for after an exam, between whether a patient is appropriate for physical therapy, as you can see in the green, or red, inappropriate, and needing immediate referral due to medical danger, thinking here more of like a 911. And then you see that there are some areas in between. The orange is inappropriate, but maybe not in immediate danger, or appropriate, but there's still some things that may highlight a potential other disease process that need to be supervised by another healthcare professional. So based off of the exam at this point, this person's really seeming to fall more into this orange box. Inappropriate for physical therapy, but they're not in immediate danger. I'm not calling 911. I'm not making sure that she's not moving in the chair, but it's something that she needs to have addressed, and addressed quickly. And again, going off of, and this is from Differential Diagnosis in PT, book that came out a while back. When we think about referring out, it's important to realize that not all of these referrals require immediate leaving. So here we're thinking, angina, chest pain, nausea, profuse sweating, incontinence, saddle anesthesias, things where we're thinking more like, cardiac or lung issues, myelopathy issues, people who are having more of like an acute diabetes issue. We talked about that positive McBurney's test from before, which shows more of kind of an acute gastrointestinal inflammation. So for example, like a swollen appendix that needs to be addressed. So those are the things where I'd say, you know what, I need to make sure you're leaving right now. And we're gonna get you set up with make sure that if you're not driving to the hospital with somebody who can drive you, that you're going to 911. And that takes a lot of reasoning based off of your comfort, because you are a point of contact with them and you want to make sure that you're setting them up on the right path. And then there's these where this patient falls into of they need to be referred, and part of the reason is because my exam didn't show anything. They're in the room, they're smiling, they're talking, they don't seem to be in acute distress, but I'm not the best professional to help them right now. And here we do need to prioritize. Yes, I'm not simply just telling you to not follow up with me and saying that I can't help. That's not what I'm saying at all. But I need to really prioritize and make sure that you understand the urgency of being seen by a healthcare professional, because potentially these symptoms can get worse, and can continue to get worse, can lead to other issues. We don't know if, I'm saying fibroids, this could be uterine cancer as well. And if it's uterine cancer, how long has it been going on? Are there any spreads to different areas of the body? So it's really important that these people get, that we do our best to educate on why it's important for them to go back and see, whether that's their primary or their, if they have another healthcare professional that may be more familiar with the area that we're referring, but not just say, you know what, I think you should go, you're done, good luck, and not follow up at all. And I think that's, there are so many different cases that I can throw out in a lumbar grand rounds. The lumbar region is really kind of the wild, wild west, and there's a lot of things, even from a musculoskeletal standpoint, that are confusing and tough to piece through. So part of me wanted to do a purely musculoskeletal case for today, but the other part of me wanted to make sure that we have a chance to highlight kind of the art of referral and the art of understanding and teasing out when we need to take a step back and bring in a physician. So I really like this quote. It says, "The hallmark of professionalism in any healthcare practitioner is the ability to understand the limits of his or her professional knowledge." And this is something that our professional knowledge has gotten us to the point of saying, you need to be seen by another professional, another body system outside of the neuromusculoskeletal system is involved. And then from there, go and try to help set that up. Now, this is somebody that especially since they came from a referring primary care physician, yes, I'm going to educate the patient on the value of going in and getting a workup. I'm not necessarily going to word that in a way that has the patient flustered or concerned, but at the same time show the urgency of having a soon follow-up. I'm going to follow up with a physician too, because I want to make sure that they are aware of these findings and make sure that they're following up with that patient if they don't get a call from them. So you want to notify the physician of your findings, or in our case, kind of the lack of musculoskeletal findings. This was a referral for low back pain. We didn't really get any through the exam. This is an elevator pitch opportunity, a summary statement. Make it quick, make it to the point, make sure that you have a recommendation. If you don't need to necessarily say, this patient has uterine fibroids, I found it, you didn't. But mention that you could be concerned of potential involvement of a reproductive system if you feel inclined to do so. But either way, just going through and saying non-musculoskeletal causes, I'm concerned with the location that they may need further workup, that's sufficient there. But just make sure to be clear, but also have action items in there. Okay. One tip that I'll also give you, just to have a really seamless conversation with the physician or the nurse or whoever you're talking to, is make sure that you have the patient's date of birth on hand. So have their full name and date of birth, because that'll allow them to really quickly look up the patient in their charts, and then it's efficient for you, it's efficient for them as well. So what's our plan of care with this patient? Do we have a plan of care? And if so, what does that look like? Is this somebody that we are never following up with? Is this just an evaluation and a referral back? Or is this somebody that we are going to see and treat in physical therapy? And that's kind of a tough question. If we think about it from what we found today, yeah, a little bit of muscle guarding, but that's it. And it seemed like the cause of that muscle guarding really seemed to be more internal. So I don't think that we're going to be the one that's going to create a large influence in their pain. But at this point, we've in a way, become their point person. So this is somebody that I would do the evaluation and I would educate them and say that I'm going to call back if I haven't heard from them in a week, or their primary care in a week, just to check and make sure that they've had a chance to talk with the physician and follow up with them. I'm not going to immediately discharge their account because I want to be I want to have the chance to have that quick follow up with them, and if they need to come back in and we realize that after going through things they still have that muscle guarding, then we can do a progress note when they come back in and continue addressing if any musculoskeletal impairments remain after it's said and done. So for me, this is an exam and wait, and if at follow up they're getting the care that they need and they're doing better, then perfect. I can write up the discharge and be happy with that, but I still want to be an ally and somebody that's there for them in between. So kind of a different case. I don't have specific, this patient, by the way, did have confirmed uterine fibroids. I don't have specific uterine fibroid exercises or an HEP to give them, but we do have recommendations on muscle guarding and other things. So I didn't end up seeing her again, but I did make sure that she got in front of the right healthcare practitioner, and she ended up doing really well. So thank you very much. Hopefully this made sense. I tried to change the format and be a little bit, articulate my reasoning a little bit more today. So if you guys have any feedback for me, by all means, definitely give it. My email's here if you guys have questions or want to give that feedback directly. I'm more than happy to help out how I can. Otherwise, keep working hard and good luck with the rest of the semester. And I'll see you guys once we start going through some in-person techniques and practicing. All right, thank you.